Now, the cutting, the 14, the first premolar of upper right of the patient, cause of the decay and the fracture of these abutment tooth. Four, 5, 6, 7, 4-unit bridge was made for the patient chewing of this upper right area. Unfortunately, however, the failed bridge work should be removed, and now this abutment tooth, one of abutment tooth, number 14 tooth, was extracted. So Dr. Chung is cutting this 14, the first premolar tooth, cutting the half and removing the remaining the part of the root teeth. So some the metal powder engaged soft tissues, the distal part of soft tissues, distal part of the gingiva. So that is the meaningless situation. So now Dr. Chung is going to another step. Checking the wall using this small round curette. Before starting this extraction of the tooth, some of periapical lesion was there. So Dr. Chung is removing all the granulation tissues and apical lesion area thoroughly using this the angled round, the small round curette. This procedure is very important to the guaranteed future site preparation. So adding the tetracycline, the powder with the saline. According to the scientific research paper, this tetracycline application of the concentration 50 milligram per 1 milliliter of saline. That is proper concentration to use this detoxification, and also sometimes this TC with the saline applied to the surface of the wood, decontamination, detoxification, sometimes exposure of the fiber. However, now this TC tetracycline the mixtures into the socket for this detoxification. Okay, now he is taking a point for in future site preparation for the osteotomy. He is going to have a flap-based surgery on this 16 area, just a small perforation through the soft tissues, taking some resistance from this bone, stop using this high-speed bar and changing the bar into this compaction drill. This compaction drill is versatile and we can use many different ways. First, actually using the regular osteotomy drill under the 2 millimeter from the sinus floor, and then use this compaction drill to removing 2 millimeter remaining of the remaining bone until the sinus floor and the ridge. However, today, Dr. Chung is going to use this compaction drill just after using Lindemann drill to pointing the future site preparation of osteotomy. And now he is using this elephant foot. This nickname of this instrument nickname is elephant foot. The small round curette. This curette, the working as a the initiation of separation of sinus membrane from the sinus floor, and after that, separating the sinus membrane from the floor, and changing the instrument like this small round curette, angular curette style. Because of this small tip is easy to apply through this osteotomy hole and checking the sinus floor and the membrane intact or not using this depth gauge. When we use this depth gauge, pushing into the sinus cavities, some of resistance means intact sinus membrane. However, without any resistance, unfortunately, it means the possible perforation. So after checking, instead of bone grafting material, he got some small pieces of collagen graft 2 as a filling material into the pushing into the sinus cavity, looks like here. And before using this small cut, Dr. Chung is always soaking these graft materials into the PDRN. This PDRN, as you know, the polydeoxyribonucleotide, the activating the soft tissue migration and elevating, accelerating soft tissue healing. And sometimes this PDRN have some effect on newborn regeneration. However, PDRN soaking situation is not what was seen today's live surgery. I guess that at every time before using graft materials and this like this collagen graft 2, Dr. Chung have some habit to use PDRN soaking with this graft material. 4 or 5 small pieces collagen graft 2 pushing into the sinus cavity, and after that using this compaction drill, the pushing inside sinus cavities. So this compaction drill have a reverse cutting edge. So the only clockwise direction used, right? This one, okay? So the normal regular speed 50 RPM. So 50 RPM case, and if you use this 50 RPM, you don't need saline irrigation. However, the higher speed, like 300 RPM, like this, you need saline irrigation. This device is a bone spreader, right? So pushing and inserting into the sinus cavities between membrane and sinus floor, and slower device rotating, spreading into the sinus cavities, bone graft. So bone graft materials or like this collagen graft 2 is spreading evenly into the sinus cavities already made the empty space between sinus membrane and floor, and already prepared for implant insertion. All the procedures are so fast, and finally implant fixtures 4.5 at 7 millimeter was inserted into the sinus elevation area, right? 4.5 diameter, 7 millimeter. So when you have when you have a pelvis surgery, first of all, you have to we have to check the thickness of soft tissues, right? I think in this case, 1.5 millimeter of soft tissues stay there, and adding the soft tissue thickness and the bone, remaining bone, the volume, and that is total the drilling depth, right? So maybe 1.5 soft tissue thickness and the 2 millimeter remaining of bone. It means 3.5 millimeter is a proper depth for the final drill for this kind of the compression drill. Okay, so fast. The installation about this 16 area. Can you remember first Lindemann, using Lindemann to taking a point, the implant fixation site, and then directly the convert to use the compaction drill, and then a little bit more and more inserting and proceed into the sinus area, sinus direction, and then finally grind out all the sinus flowers gone away, and then this autogenous bone pushing into the sinus cavities between membrane, intact membrane, and sinus floor. And that is key procedure and key role of this compaction drill. Okay, move to number 24 area. Actually, as you know, the high-speed bar applied to making a proper point osteotomy. The cause of this socket area, sometimes this high-speed bar is better, the useful, than the lower speed, the Lindemann drill, or some another final drill. Why? Actually, cortical bone plate is make it easy to slippery when we use a slower, lower RPM drill use. So first, the high-speed bar to make the proper point, and then changing the drill with the final drill, and normal procedure and normal protocol was applied to make osteotomy site. And then finally, he is going to use this graft material. And this one is osteon, osteon 3 collagen. Sometimes we can use osteon 3 collagen. Today, Dr. Chung is using the osteon genocollagen. Osteon genocollagen and osteon 3 collagen is the same as collagenated bone. However, the particle is a bit different, you know. Osteon genocollagen is a naming showing us the key, the genograft from the bovine bone. The collagen binders from the pore side. However, this genograft, and however, osteon 3 collagen means alloplastic bone, as you know, osteon 3, so particle. Okay, now this applied collagenated bone was osteon genocollagen. Okay, so the palatal positioning is the proper way to install. When we have this, the premolar areas implant insertion, right? The always empty space between socket wall and implant, the surface should be remained in the buccal area. That is correct positioning. However, there are no more the buccal, the empty space means a little bit wrong position, right? So when you solve this kind of situation, you may retrieve implant fixture and then take away another positioning for the proper the initial drilling, and then the reinstallation with the proper positioning, right? So, you know, this number 14 areas, the proper positioning perfectly, the palatal wall engaged implant installation is a standard protocol. And okay, so after inserting the collagen, osteogenesis collagen, the grafting material, and implant fixation, now the small gap between soft tissues and implant neck portion filled with collagen graft tool that is already introduced to you when I started this live session. So collagen graft tool is a very soft tissue friendly graft material. So promote, accelerate soft tissue healing, faster soft tissue healing. So the very faster epithelialization will be seen on this extraction area. It means the faster healing means stable all the situation, make stable all the situation, make all the situation stable, and make a new bone formation faster. Okay, suture was started. First, horizontal matrix suture was done, and after that, he made another suture, the modified horizontal suture. The proper side, same as horizontal matrix suture. Oh, okay, so now he is doing horizontal suture, horizontal matrix suture again. For the popular adaptation. When we saw this suture technique, we can imagine some of a surgeon's concept and surgeon's style. So he want to make one more stitch about this distal area of socket of number 14. This the bright tissue level implant fixtures is getting it getting easier initial stability, higher initial stability due to its knife edge thread and the belly style. Okay, thank you for waiting. This photo, intraoral photos, shown us post-op view just after finishing the surgery. So this one is post-op cone-beam CT view. Left side, number 16 area. Right side, number 14 area. 14 area is a socket, immediate socket implantation case. So the key is here. Always a lingualized and palatal positioning implantation, right? So, you know, this socket will be ovoid shape. However, we need some proper positioning, especially premolar area, molar also. So, you know, the palatal engagement is essential part to make a proper positioning. vocolingually, right? As I mentioned before, always empty space between socket wall and the surface of implant fixture should be on the buccal, right? So we have bone packing. We need a bone packing on this labial or buccal, the empty space for the gap filling or some trivial procedure when we have immediate implantation after extraction. According to this principle, number 14 areas, very nice, well done installation. All the implant fixture have a correct direction, engage palatal cortical bone plate of socket, and the filled with the bone graft material with osteogenic collagen on the buccal side between the buccal socket wall and implant surface. Fortunately, this 14 area intact buccal bone wall. So we can expect very faster new bone formation with the osseointegration on this implant surface area. Maybe these areas will be the faster construction with a temporary with PMMA with custom or a dual abutment. Compared to this area, what about the 16? This 16 area, the remaining bone was a small bone volume. The much as smaller as the bone volume. Actually, a smaller bone volume means need more time, new bone formation and healing, right? So we can see this clear on the right upper area, the blood vessel, the artery, the PSAA artery was seen, the clear on upper right, the inside of the sinus wall, right? And the little bit H, this the membrane areas filled with collagen graft too, as you know. So we need more the evaluation about this collagen graft 2 filled space turning to new bone formation or not. I expect these areas filled with no new bone formation, like as a bone graft material inserted situation. Intraoral view, 14 areas, very fast healing in even though the extraction socket area, 16 areas was panic. So soft tissue was very nice. So will be seen very nice. And after that, intraoral scanning for PMMA temporary. Dr. Chung shown us and introduced us about this intraoral scanning for the temporary provisionalization, right? For the final restoration, he always used this BTS technique. BTS technique means the bite tray technique. So rubber materials, using rubber material and bite tray, and take impression and the scanning with the model scanner and take some image and the work flower in the CAD and CAM procedure and machine. And CAD image here for the PMMA temporary. And temporary crown was shown us finally. And this temporary crown delivered to our patient mouse. Actually, in some clinic, maybe this temporary crown was the same day as surgery. However, the in-house the laboratory facilities gave us a good benefit when you have this kind of immediate implantation and immediate temporization case. The provisional restoration was applied into the patient mouse. The panic area is slightly make some space for the utilize toothbrushing. Okay, actually, I think this kind of surgery situation is very nice, well done. However, we need more the evaluation about this collagen graft 2 graft material. I believe, however, I believe this collagen graft 2 filled with empty space between sinus membrane and sinus floor will be turned newly forming bone cause of the many evidence was introduced by published article, right? That without any bone graft materials working as a scaffold, we can see the new bone formation without this bone graft material scaffold. That is the factor, that is the evidence of a published paper. So I believe this empty space turning to newly forming bone. I don't know the time sequence. Actually, the normally bone adding cases, we estimate 4 months, right? However, in this collagen graft 2 case, I'm not sure the exactly new bone formation time point. However, gradually this empty, the field with collagen graft 2, the space turning to the newly forming bone. Okay, let's move to today's Q&A session. Yeah, here, a very nice question. If a membrane population had occurred during today's live surgery, how would you have managed it? Would you have immediately switched to the lateral approach or prepared to reschedule the procedure? The basic principle is here. When you have sinus elevation with a crestal approach during the procedure, some of a small population will happen. At the time, the population case, actually we can move to directly immediately switch to lateral approach, make some flap reflection, make lateral window, and same as lateral approach protocol, to separate the sinus membrane from the lateral wall and elevate all the sinus membrane with all the direction, the medial and distal and lower. And after that, pushing the graft material into the sinus cavity with the implant fixation. At this time point, some surgeons want to use some collagen matrix to cover the small population area. However, another surgeon doesn't want to have any collagen graft material, the collagen matrix materials, cause of the small population can be easily the closing under the 2 millimeter case. And also another one reason is here, if we use collagenated bone like osteon 3 collagen or osteon geno collagen, this collagenated bone is close this small population area without any membrane application. Depend on 2 of causes. The areas successfully covered and overcome when you have a small population during crestal approach case. However, the big and the wide population when you have a crestal approach, if the remaining bone is the smaller. For example, the indication of crestal approach, the remaining bone will be 4 to 6 millimeter. However, some surgeon and some dentists want to have a crestal approach when you have under 3 millimeter, 2 millimeter, even though the 2 millimeter, you can try the crestal approach. However, during this procedure, some small population make it easier, make it bigger, the population size. So at this time point, you may stop the procedure of crestal approach and start to the lateral approach style to make incision and flexion, lateral window opening, and separation of the sinus membrane from lateral wall and floor, and close if bigger than 2 millimeter should be closed with collagen sponge or the collagen membrane, and then put the graft materials. Smaller than 2 millimeter, about 2 or 3 millimeter, just the collagenated bone graft packing is enough to have the sinus elevation without any scattered into the sinus. Graft. The graft materials doesn't have any scattered into the sinus cavity when you use this collagenated bone without any membrane, right? So it is the standard, the established protocol. However, the smaller bone volume, as I mentioned before, 2 millimeter, 3 millimeter, the challengeable case, trying to the crestal approach, unfortunately, we can get big population. So depend on the surgeon skill, the experience, and the anatomic situation. It means the position of PSAA, the artery, the running. So lower the artery running case, actually maybe a higher risky situation that will happen when you have a lateral approach. However, higher the running case of the artery is more simpler and more safer and more easier to make a lateral window and lateral the approach case. So depending on all the different situations, you have to decide, go to lateral approach or the wait and the try again with the crestal approach. I think 4 or 5 months later, right? That is my answer about your question. Okay, I'm going to finishing today's the live and the follow-up session. Thank you for watching, guys. We will have a next live surgery the August 22nd, 7 p.m., the same time, same day. Thank you for watching and see you next time. Bye.